Hi everyone, thanks for listening to my presentations. Today I'll be talking about hyperthyroidism, and I'll limit myself to causes and how to make the diagnosis of hyperthyroidism as part 1 of 7 today. Okay, let's go. Hyperthyroidism could be broadly divided into two when it comes to the causes. A. Hyperthyroidism with a normal or high radioiodine uptake means that the problem is within the thyroid gland. Okay, so later on we'll get to diagnosis and we'll make use of radioiodine uptake. If there is normal radioiodine uptake or very high uptake, then the problem is within the thyroid gland itself. If that is not the case, hyperthyroidism with close to absent radioiodine uptake indicates that there is inflammatory process going on, and that destruction of the thyroid gland and a release of the already formed hormone into the circulatory system is the problem. Let me explain. Like I've said, A means radioiodine uptake is good or very high or normal. The problem is within the thyroid gland. But if radioiodine uptake is absent or very, very low, it means there is inflammatory process going on. It means that the thyroid gland has been destroyed and then the hormones have been released to the circulatory system. It could also mean if the uptake is very low or absent, that we are dealing with extrathyroidal source of the thyroid hormone. Epidemiologically, more females will be more affected than males at ratio 5:1 respectively. And we're going to find hyperthyroidism more in older women, in smokers. It's not that non-smokers cannot have hyperthyroidism, but smoking will increase the chances. Also, in Graves' disease found in younger women, toxic nodular goiter, that's also found in older women more. Graves' disease is the commonest cause of hyperthyroidism, and we're going to find out more in younger women. Lesson 4. Ectopic hyperthyroidism will occur when we're dealing with Struma ovarii. I will go into details of that later on. Also in metastatic follicular thyroid cancer. Exogenous thyroid hormone intake. Why will exogenous thyroid hormone intake lead to hyperthyroidism? What of when we are treating hypothyroidism with levothyroxine? If that levothyroxine is taken in a very high dosage, then it will tilt the affected individual to hyperthyroidism. It could be intentional suppressive therapy, and of course infarctious hyperthyroidism, where there is a mental disorder and the individual has deliberately or consciously ingested levothyroxine. Human chorionic gonadotropin mediated hyperthyroidism. This might be surprising to some women, but it's possible. In human chorionic gonadotropin mediated hyperthyroidism, there will be hyperemesis gravidarum, and there is likely going to be underlying trophoblastic disease. In thyroiditis, it might be subacute gangliomatous thyroiditis, Kuvan syndrome, or lymphocytic thyroiditis, or silent thyroiditis, or postpartum thyroiditis, amiodarone, and of course radiation. You can check my channel for full presentation on amiodarone, and you get all effects of amiodarone on thyroid gland and the hormone. Still on causes, it could be thyroid stimulating hormone mediated. And in that wise, we'll be dealing with thyroid stimulating hormone producing pituitary adenoma. Okay, we are familiar right now from the published presentations by me that anterior pituitary is responsible for producing thyroid stimulating hormone, and that will later work on the thyroid gland to release the thyroid hormones. That is when we are talking about hypothalamic pituitary thyroid axis. So when there is pituitary adenoma, particularly anterior pituitary adenoma, more TSH will likely be produced. And it might be non-neoplastic thyroid stimulating hormone mediated hyperthyroidism. Iodine induced. Iodine can induce hyperthyroidism. Autoimmune diseases. Particularly when it comes to thyroid gland, we might be dealing with Hashimoto's or Graves' disease. They could both lead to hyperthyroidism, but Hashimoto's will end up with hypothyroidism. But I won't leave this page without reminding you that once you pick an autoimmune disease in anyone, it's likely that you are going to find more. For example, someone is with pernicious anemia, another with type 1 diabetes mellitus, another one with ulcerative colitis or Crohn's disease or celiac disease or Sjögren's syndrome. You have to rule out the thyroid disorders as well. And the same is if you find autoimmune diseases affecting thyroid gland like Graves or Hashimoto's, rule out other autoimmune diseases as well. Goiter. Toxic multinodular goiter could lead to hyperthyroidism. Drugs. Tyrosine kinase inhibitors, lithium, immunotherapy with interferon alpha, nivolumab, pembrolizumab, and ipilimumab could all cause hyperthyroidism. Also, epoprostenol, that is used for the treatment of pulmonary arterial hypertension, a prostaglandin, could also be responsible. So anyone taking all these medications should watch out. And don't forget, I have talked about amiodarone before now. Metastasis. Metastasis to the thyroid gland could shoot out the thyroid hormones. Acetotoxicosis. Acetotoxicosis simply means combination of Hashimoto's and thyrotoxicosis. If that's the case, the hyperthyroidism we're dealing with right now is secondary to that. How do we make the diagnosis? Of course, we do our history, thorough history, physical examination. We'll go through all the clinical features, right? Then we'll head to lab. Thyroid function test. Overt hyperthyroidism, we present with decreased TSH, less than 0.05 milli-international unit per liter, and we'll be battling with very high T4 and high T3. If that is the picture, is overt hyperthyroidism. In subclinical hyperthyroidism, the TSH will be low, but compared to overt hyperthyroidism, it will be a bit greater than 0.05 milli-international unit per liter. So it will not be as low as the case will be if it is overt hyperthyroidism. Another clearly defined feature here will be that T4 will be within normal range, and the same with T3. Remember, in overt hyperthyroidism, T4 will be high and T3 will be high. Another feature here is that we might be dealing with no clinical symptom or symptoms at all, or if we are going to find any symptom or symptoms, it will be very mild. That will be all about subclinical hyperthyroidism. We are not done yet. We are still in the lab. We'll assay the lipid, and we're going to find decreased total cholesterol, decreased low density lipoprotein. We are happy to hear all those, right? But something bad is happening here. We are still going to find decreased high density lipoprotein. No, to those who belong to the school of cardiology, we don't want to see that. We want to see high or increased high density lipoprotein. It's good we have low total, low level of low density lipoprotein, but we need increase or raise or high level of high density lipoprotein. Hematologically, we are going to pick normochromic, normocytic anemia because it's anemia of chronic disease. And there will be increased alkaline phosphatase and increased osteocalcine. In thyrotoxicosis caused by Graves' disease, that could also be known as T3 toxicosis. Another name is nodular goiter. Any of these three names, we are talking about the same condition. If that is the case, we are going to find more T3. Okay? T4 will also be increased, but it's going to be less compared to T3. What's happening? Yes, T4 conversion to T3 is increasing. That's why we are finding more T3 compared to T4. Although T4 is not low, it's also high. Okay. And then when we assay the TSH, it will be low or decreasing. So when we have this picture, low TSH, more T4 being converted to T3, T4 is raised but less compared to very high T3 level, then we are dealing with T3 toxicosis caused by Graves' disease, or is possible in nodular goiter. Now we are done with T3 toxicosis. Okay, moving to T4 toxicosis. T4 will increase with amiodarone that will prevent T4 conversion to T3. Okay? We are now finding more T3 because T4 is prevented from being converted to T3 by amiodarone. So that's why we're going to find more T4 compared to T3. We will have decreased T4 conversion to T3, like I've just explained, and it's likely happening in non-thyroidal illness. So T3 will be in normal range. Why? Because T4 is not converted to T3. But TSH will be low. That's why we'll be thinking of hyperthyroidism here. So T4 toxicosis is possible. How about TSH-induced hyperthyroidism? Somebody is asking me, is that possible? But it's very rare. In that case, we'll be querying pituitary adenoma that is secret. I will be querying partial resistance to the feedback effect of T4 and T3 on TSH secretion. In that level, when we do our thyroid function test, T4 will be high, T3 will be high, but TSH might be normal or actually increase. Hypothyroidism is possible in critically ill non-thyroidal illness, either being admitted to the hospital, bedridden for a long period of time, or has chosen to be treated at home but critically ill. Then we might be having problems with the thyroid hormones. It's likely we're going to find decreased binding of T4, decreased thyroid binding globulin, displacement of T4 by medications, or decrease or normal T4 with decreased T3 or normal and decreasing thyroid stimulating hormone. But note this, the thyroid stimulating hormone will be less than 0.01 million international unit per liter. And when we find that, when we find TSH less than 0.01 million international unit per liter, that is non-thyroidal illness. And that is the only condition we're likely going to find that. Okay, effect of Biotin. If someone should ask me, what's the problem with Biotin and hyperthyroidism? Then I will tell you that though Biotin is one of the big complex, the multivitamin you take just on your own, but it can interfere with thyroid function test. It can cause drop in thyroid stimulating hormone, give a picture of increased T4 and increased T3. So what we're going to do is stop the test, stop Biotin intake, or stop that B complex intake, repeat the test about 2 to 4 days after, and you get a clearer picture. Definitive diagnosis. Oh, you're saying, oh, so all we've been talking about is not definitive? I'm not saying that. But in medicine, we always have definitive treatment or definitive diagnosis or gold standard. Here, the gold standard or definitive diagnosis is radioactive iodine uptake and scan. But we cannot have radioactive iodine uptake down in pregnant women. So radioactive iodine uptake and scan, that is not for pregnant women. Thyrotropin receptor antibodies for pregnant women. You can also have thyrotropin receptor antibodies for non-pregnant women as well. But when I said you can't have radioactive iodine uptake with scan done in pregnant women, then how do you make the diagnosis in pregnant women? Go for thyrotropin receptor antibodies. For non-pregnant, you can use either radioactive iodine uptake with scan or thyrotropin receptor antibodies. But thyrotropin receptor antibodies will not be applicable in case of goiter or Graves' disease. Otherwise, you can have ultrasound done, you can have radioactive iodine uptake done if not pregnant. If you are still confused, you've done everything that the doctor has been talking about in the last 17 minutes, but you are still confused, don't worry. Keep the record you have today, repeat the test in the next 2 months. With that, I've come to the end of this very presentation. The next presentation will be about clinical features of hyperthyroidism, and that will form part 2 of 7. Thanks for listening. Please remember to share and subscribe. I appreciate it.